Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and today I want to dive a little bit into posterior epistaxis. We see a lot of anterior epistaxis in the ED, and while there is some controversy around things like tranexamic acid, management is pretty straightforward. Administer a topical vasoconstrictor, hold pressure, plus or minus TXA. If that fails, put it in packing, send the patient home. Posterior epistaxis is a bit different. It is a much more dangerous pathology, and it's uncommon, which makes us a little bit uncomfortable with management. As with many things, recognition is really key. It's easy to confuse anterior and posterior epistaxis. In posterior epistaxis, we are looking for heavy bleeding both anteriorly and posteriorly into the oropharynx. These patients often will have a tough time speaking because they're continually clearing blood, trying to spit it out. Tachycardia is common. Hypotension, not so much. It can happen. It's not unexpected, but it is not the norm. This is pretty different from anterior epistaxis, where you almost never see hypotension. It's usually a little bit of hypertension, and even tachycardia is relatively uncommon. The easiest way to clinch the diagnosis is that when you put anterior pressure, proper anterior pressure, you still have posterior bleeding. In fact, even if you put in an anterior pack, you're going to have posterior bleeding. If you have continued hemorrhage after placement of a good anterior pack, you should pretty much assume that you in fact have posterior epistaxis. Treatment is going to start with the basic things we always do. IV, supplemental O2 if necessary, place the patient on a monitor, consider blood products if they look like they've lost a ton of blood or they report heavy bleeding at home, and then strongly consider reversal of anticoagulation. This is often going to be necessary in order to get control. Our next step, of course, is going to be to stop the bleeding. Now, before you go in to stop that bleeding, you really want to put on good personal protective equipment. These things can bleed like stink. I have seen both residents and attendings covered in blood after taking care of a patient with posterior epistaxis. Gown, gloves, and most importantly, eye protection. There are two main ways to get control of the bleeding. The ideal situation is that you have a commercial posterior pack. These things have two balloons, one for the anterior and one for the posterior. You're going to place that device straight back parallel to the floor of those sinuses, just like you would put an anterior pack in. Inflate the anterior balloon with air. If you still have bleeding, now you're going to inflate the posterior balloon. Most of the time, that is going to control hemorrhage. The problem is that many of us don't have commercial posterior packs available in our emergency departments or in our urgent cares. In a pinch, a Foley catheter actually can do a great job here. We're going to place the Foley catheter into the nose just like we would put in a nasal tampon. Once you see the tip of the Foley in the posterior pharynx, you're going to inflate the balloon, probably about 5 to 10 cc's, and then you're going to have to pull that back a little bit, provide a little bit of traction, and secure it in place. Usually this can be done simply with tape on the nose that's going to hold that posterior balloon in place and tamponade bleeding. Once you get control of hemorrhage, there are some things to consider in post-placement care. The first is, should I give this patient antibiotics? We have debunked the idea that anterior packs need antibiotics. We've got a great post on Rebel EM. We'll link that in the show notes. The literature doesn't really defend whether you should or should not do antibiotics in posterior hemorrhage. It's really, the data here is pretty sparse. There's not good data compelling us to do it, but it is reasonable to give the patient a dose of antibiotics. Often you're going to do this in conjunction with your ENT. If they want antibiotics, I don't think it's that big of a deal. The other thing to think about is, where does the patient need to go in terms of admission? The classic teaching was that all of these patients had to go to the ICU because they were at risk of life-threatening Brady dysrhythmias from that packing. Truthfully, there is no literature to tell us that a life-threatening Brady dysrhythmia is a real thing. The two articles that often get cited are one in Laryngoscope in 1971 and then one in Laryngoscope in 2010. Neither of these really says that any patients get life-threatening Brady dysrhythmias. It's unclear why they are cited. In fact, that 1971 article never mentions any cardiac events. So it does get cited, but it doesn't really seem relevant. Before you throw out that the patient needs to go to the ICU, though, it is important to consider the fact that hypoxia can often occur in these patients. In that 1971 Laryngoscope article, they found a drop in PaO2 by about 20 millimeters of mercury. All of the patients, though, in this article were sedated. So it's unclear whether it was the packing or the sedation. Probably more relevant is an academic emergency medicine article in 1995 that showed that about 20% of the patients who had a posterior bleed that were included in this study required a surgical intervention. So with that in mind, it might actually make sense to place these patients in an ICU or a step down where they can be closely monitored for continued bleeding. And most of the ENTs that I've talked to say, yeah, we know the bradydysrhythmia thing isn't real, but we do know these patients often will rebleed, they'll start hemorrhaging again, so they probably should be in that higher level of monitoring. Before we wrap up for this week, let's hit a couple of big take-homes. Posterior epistaxis, unlike anterior epistaxis, is dangerous, it is uncommon, and we are often uncomfortable with management. The key is going to be in identification and then tamponading that bleeding source, which is best done with a commercial posterior pack, but in a pinch can be done with a Foley catheter. Again, you're going to insert that Foley catheter, look for the tip in the posterior pharynx, blow up the balloon, and then provide traction to balloon tamponade whatever is bleeding. And then finally, these patients often will need a surgical procedure. Rebleeding is common, so placement in a higher level of care makes a lot of sense. And don't forget to get your ENT consultant to the bedside as soon as possible. That's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks on our cast. In the meantime, don't forget to hop on over to the site, check out all the fantastic posts from our faculty, and until next time, stay safe.